43 topics that are high yield that you must know for your PMHNP board certification. Wait a minute. Are we talking about the dumping sheet? Yes, we are. Right now, I am going over 43 topics that I would do for my own dumping sheet. Pick what's useful to you and create your own dumping sheet. My name is Dr. Lopez. Come with me. Hey guys, this is Dr. Lopez with NP Exam Coach. Today I am going over 43 topics that you must know for your PMHNP board certification. That is the dumping sheet. Pick what's useful for you and create your own dumping sheet, right? So do not memorize 43 topics because they will be difficult for you to remember on your test day. Basically, pick what's important for you. Let's start by saying 2CDT, the clock drawing test. This is a 2, this is a clock, deficiency in the parietal right hemisphere. Why it's important? You can do in 2 minutes. You do the clock and drawing. Deficiency in this area means there is a problem in the parietal or right hemispheres. Topic number 2, it is the limbic system. How do you remember the limbic system? Hypothalamus, which is the thalamus, plus the hypothalamus, the hippocampus. Here I want to highlight the stress. If the question says stress, think of the hippocampus. If the question says angry, aggressive, smell, think of the amygdala. Topic number 3 is the dopamine pathway. How are you going to remember the dopamine pathway? Many men never travels. M for the many is the mesolimbic. Here you have an increase in dopamine causing the positive symptoms. Men, the mesocortical pathway. Here you have a blockade or decrease in dopamine that cause the negative symptoms. The never niger striator. Here you have a dopamine blockade causing increase in acetylcholine. Then you have the travel, and that's the tuberofundibular pathway. Here you have an imbalance of prolactin, increased prolactin, causing problems here, right? Now I want to go back to the never, the nigrostriatal pathway. When we talked about the nigrostriatal pathway, we are saying that acetylcholine is dominating. Okay, when that happens, we have few problems, right? And I put the problems here as AAA, PT. Okay, what are the problems? Well, acute dystonia, right? What do you give? Cogentin. Then we have another A here. Can you guys guess what the other A is for? Well, if you said it, akathisia, you got it right. What would you give for akathisia? Not cogentin. Well, you could give cogentins, but most likely your test may say beta blocker. So I want to highlight the second A for akathisia, you give beta blocker. The third A is for akinesia. Then you can give again cogentin. The P is for the Parkinsonian-like symptoms. What do you give? You guess it, cogentin. Then the T is for tardive dyskinesia. What you are not going to give is cogentin. Here, most of the time, you will reduce the dose or change the medication. Okay, moving on. Remember, this is dumping sheet. It is not a in-depth review. For in-depth review, please make sure you review our PDFs and the videos on each of the modules. Well, here I want to talk about inducers. When you have an inducer, it induces the drug out, meaning you have less available. So your job is to give more medication because more medication is out, less available. How are you going to remember the medications that causes inducers, right? Well, think of it as drop, act, scam, GBS. Well, what the heck that stands for? The D is for dilatin, the R for revamping, revamping, the O for oral OCPs, the P for phenobarbital, the A for antiviral, the C carbamazepine, T tobacco smoking. That's an important one you need to know. The S are for your sulfur drugs, right? The C, cyclosporine, A for alcohol. But this A here is for a chronic alcohol use, M, methadone. The G is for the glycerin drugs, the antifungal drugs. The B, the barbiturates, and finally the S for St. John Wort. Here you have your inducers that cause medications that cause less of drugs in the body, meaning that for your job you need to increase the dose. How about inhibitors? Well, more medication stays in, and therefore you need to decrease the dose, right? Well, do I have an acronym for inhibitors? Yes, I do. Check it out our course. Do you need one? No, you don't. I would memorize only one for inducer, drop, X, scam, GPS, and I would play it that way. Moving on, you have to kind of be very mindful about serotonin syndrome, specifically how serotonin syndrome and NMS relate to each other. These are very, very known questions to be in any test whatsoever. Well, let's start by saying, let's review how they are similar and how they are different. Okay? Before we do that, let's cover what serotonin syndrome. So, serotonin syndrome is caused by excess of serotonin. What are the symptoms? I would say 2S, which stands for the 2S, the 2H, the 2DIs, and the 2 muscles and 1 tick. Okay, so the 2H here, it stands for the 2 highs, right? Let's start with the 2 highs. It stands for the high heart rate and high BP. Then we move for the 2Ds, that's diarrheas and diaphoresis. The 2H stands for headache and hallucinations. The 2 muscles stands for muscle spasm, rigidity, very important, okay? Let me write it down here for you. 2 muscles, right? Muscle spasm or rigidities, and a tick. T is tremors, I for irritability, C is for confusion, and finally, what you give to treat is the final C. It's cyproheptadine. Okay. Now, NMS. When you're talking about NMS, it is caused by a antipsychotic like medication. Okay, so how are they different? Well, when you're talking about NMS, you have lead pipe rigidity, mutism, myoglobin is increased, and the CPK are increased. When we're talking about serotonin syndrome, you have hyperflexia, jerksia is means seizure activities of extremely jerking like. What do you give? Cyproheptadine. NMS, what do you give? Well, you have 2 choices. The treatments with B, for you to remember, bromocriptine. 2DA, meaning is the dopamine agonist, or the D for dantrolene. How are you going to remember? Rock T, then rock T, rigid muscles. Got it? Hope you do. Well, let's move on to our PDF number 2. On PDF number 2, we cover NMS. We cover MSE and NMS. When we refer to MSE, I want you to be cognitive of the entire process. But the ones that students often get confused is thought process versus thought content. Well, thought process is how how the thoughts are being processed, and the thought content is what you're thinking of, for example, hallucination. So I have here the suicidal ideation under thought content. Okay, so again, thought process is the organization of your thoughts and ideas. Thought content, it is the patient thoughts and ideas, which can include delusional, overvalued ideas, preoccupations, especially suicidal ideation. So that is part of your MSE. Again, the MMSE, as you know, because you have been in my course, it's also called the Fosting test. Well, I have here the IR going up, and it's good, meaning that high score, it's good. We want that. For the MMSE or Fosting test, you want to really remember few things. And you can do this by memorizing ORRALF and the money signs. What does it mean? Well, these are things that you must know. Let's start by saying the first letter, right? Which is the orientation. Here I have highlighted the R and the R, okay? Which means recognition. When you recognize, you want to know that is under 1 minute. Recall is calling the items after 5 minutes. The A is for attention. How do you assess attention? Series of 7. The L is for language. And I don't want you to forget the F, which is fund of knowledge. The money sign here means that it's ching ching. You are charged. You cannot use it freely. So what tests can you use fairly? The mini cog, mocha, and the slum. Guys, pay attention here. I have another clock in the mini cog, which means the mini cog, you are also doing the clock drawing test. These are free. You can use anywhere. Let's move on with few things on module 2 from our PDF. Remember we talked about SEWA and cows. Do not confuse SEWA and cows, but here are a few things about SEWA that I want you to at least think about it if it's worthy to put it on your own dumping sheet. 5 plus 15, meaning that, hey, well, actually, I'm sorry, 8 plus 15, right? So let's do this a better 8 so we don't get confused. 8 plus 15, meaning that the treatment of SEWA, which is for alcohol withdrawal, it starts at 8. When it gets to 15, now we have to do PRN plus S, meaning schedule. If someone has liver problems, what are you going to give? Lorazepam. If the person doesn't have liver problems, you can give diazepam. Now remember the DAN, the disulfiram, acamprosate, and naltrexone, not for the SEWA, but for drug maintenance, alcohol maintenance. Moving on to cows, 5 plus 13. 5, what you give? Clonidine. 13 and plus, you give buprenorphine or Suboxone, your choice. Some people may give methadone. I don't advise. I would pick one of the two. Now, if someone is going through opioids withdrawal, how do you think they would feel? Pretty bad, right? However, it's not as dangerous as alcohol withdrawal. Alcohol withdrawal can kill you, right? So opioids withdrawal is absolutely nasty, and we have to keep track of those symptoms. When we refer to opioid withdrawals, how do we know what are the symptoms or which ones are important for you to kind of like know? I did a little acronym. It's called YAPDPLRSI, which means going through opioid withdrawals, yawning. The I is for irritability. The P, I want to highlight this. If you're going through opioids withdrawal, you will have pupillary dilation. The other P here, okay, is for pillow erection, or better known as goosebump. Then you have some muscle aching, lacrimation, or is also renal hair, things coming out of your nose that you don't want to. The S is for sweating, and finally the I is for insomnia, right? So you can say yep for dope, the D here, so meaning the opioids, right? P, I want you to remember pillow erection and also pupillary dilation. Okay, so let's keep going on our module 2 PDF. Okay, so we talked about the MMSC, also known as the Foston test. Now, the SLUM and the MMSC, they both scales that are good for assessing cognition. I want you to remember that high score, it's good, right? So they start both at 30. Now, the SLUM, when you get below 20, now becomes severe. MMSE below 9 is severe. Moving on to other scales, PHQ-9, GAD. Well, I have them both at 10 to 14 right here. So it makes it easy for you to remember. Then we move on to HAM-D. Remember, if you're in my class, add 4, 14 to 18, you have HAM-D. Other scale, Beck. Remember, my grandma, 1929, she was born in 1929. Her name was Beck. So there you have your scales for depression. Which scale are we missing? Edinburgh, okay? We don't need necessarily to know the numbers, but we need to know that Edinburgh is a special scale and it's all about collaboration. You may ask with who? Well, our OB docs, right? Now we are going to the last scale, which is the HAM-A. Guys, remember HAM-D 14 to 18. If you add 4 more, you'd get 18 to 22. But just remember that we are going to 6 here instead of 4. We did PHQ-9, GAD 7, 10 to 14. We added 4. We have HAM-D 14 to 18. Sort of adding 4, we have HAM-A 18 to 24, 22, but we know the correct number is 24. My grandma, she was born in 1929. Now you know your MMSC, your SLAM, PHQ-9, GAD 7, HAM-D, Beck, Edinburgh, and HAM-A. That's it. That's easy, right? That is your scales in the nutshell. Let's move on to the topic number 10. Here we have Siebert. Remember, Siebert is a brief intervention. What scales do we use? Outed. Which scale is better? Outed or cage? Outed is better. Why? Because it's more comprehensive, right? Now, cage, 2 plus is a positive. You need to know what cage is by the letter, right? Have you ever felt cutting back? Annoyed. C, right? And A. Then the following scale is the dust. Okay, so for youth and adolescents, you need to know what the dust is for as well. So as we move on in our topics here, also on module 2, we want to address few things. One is delirium. What is delirium? Well, delirium is a short loss of consciousness, not consciousness, but orientation, right? You want to assess for what? UA, okay? And if the patient is severely agitation, you have the H for haloperidol as one of the options. First, try to do non-pharmacological intervention. If not possible, haloperidol is one of those four. So if the delirium is kind of short, what would be long? Well, dimension. Long meaning it takes a long time, right? So it doesn't happen overnight. It takes a little bit of time. So here you have your dimension. So let's break it down, dimension, a little bit more so that you fully understand at least the principles of dimension. So dimension, it takes years to develop, not weeks or months. It takes years to develop. And when we refer to dimension, we really want to talk about the cortical. That's why you have your C, and the subcortical, yes, below the cortical, okay? When we refer to cortical, we want to think about language and memories, okay? So cortical, language and memories, it's here for you um, to oversee the subjects that we cover in detail in our course. Now the S for the subcortical is for depression and modem issues, okay? So when we talked about the cortical, I want you to think of PAC, okay? PAC. When we talked about the subcortical, PHH, well, what does it stands for? Well, let's think about this way. You have to know which ones are cortical and which ones are subcorticals, right? So if you think about the cortical ones, which involves language and memories, which ones do you think first, right? Subcortical. So the cortical means that uh, things like Pick's disease or Pick's disease, also known as a frontal temporal dementia. Another A, the A here is for Alzheimer's, and the C is for the Creutzfeldt-Jakob disease. So PAC, cortical, language and memory. Subcortical, depression and modem. So what do you think the P is here for the subcortical? The first P here is for our subcortical, and it is for Parkinson like symptoms, dementia. Then you have your H for Huntington's disease, and your other H is for your HIV dementia. Moving on now to our PDF number 3 here. Okay, so what we have here for PDF number 3. So if you are with us, we talked about in excruciating detail about our TSAs, TSH, right? You guys remember what we covered about the thyroid volumes, right? Let's start by saying the thyroid volume, the normal thyroid volume. So what do you want to know about the normal thyroid value? So the normal thyroid value is 0.5 to 5.0, okay? So if your TSH is increased, your T3, T4 is decreased, you have hypothyroidism. How do they feel? They feel slow and cold, cold and slow. If your TSH is low, but your T334 is high, what do you have? Hyperthyroidism. How do they feel? Hot and flush and fast, right? Fast heart rate. They eat, don't gain weight, right? They're heat sensitive. That is your hyper. Moving on to the next topics, number 13, that is your Tourette's. For Tourette's, you need 2M plus 1V, 2 motor symptoms plus 1 vocal. What do you give? Clonidine is one of the options you give. Well, I have OCD here. Why do I have OCD? Just to remind you not to pick a answer as Tourette's if you hear a tick. OCD also comes with ticks. You have to pay attention and read the question carefully. Topic number 14, schizophrenia. There are a few things that you need to know if you put a schizophrenic patient in a MRI. Everything else is most likely to be decreased. What is increased is your ventricle size. I also want you to know the age, right? The age for schizophrenia, it's male 18 to 25, female 25 to 35. Guys, this is not a comprehensive review. These are bits and pieces of things that you must know to pass your PMHNP board certification. We move on now to module 4, right? We're moving on quite fast. And here we have a very important topic. Perhaps this is one that I love the most is therapies, right? See, and let's start with Erickson. Erickson, right? Stage of development. Well, let's start here by T and M, which means trust versus mistrust, right? Then you have autonomy versus shame. Next, I, N, and guilt, which means initiative versus guilt. IN versus IN means industry versus inferiority. Then you have ident versus confusion. Ident versus confusions. The next one's intimacy versus isolation. Then we have generativity versus stagnation. And here we have integrity versus despair. By the way, I would memorize just one of each and not two of each, right? I would put just one on your piece of paper. But here is what I would absolutely do. You know that on Erickson's stage, age is important. So knowing the age, it is super important. So I would memorize this little table right here. So 2, the next one will be 2 times, the following 2 times, plus 8, 15, plus 30. That's it. Easy, right? So let's see how that goes. Well, when we talked about trust versus mistrust, it starts at age 1. 2 plus 1 is 3. 2 times 3 is 6. Then you drop the 6 here. 6 times 2 is 12. Then you drop the 12. 12 plus 8 is 20. Drop the 20. 20 plus 15 is 35. Drop the 35. Plus 30. You have up to 65, right? Here, up to 65. 65 and plus, you have the last stage. Here you have here 35 plus 65. It's generativity versus stagnation. So if you do 2 plus 1 is 3. 2 times 3 is 6. Drop the 6. 2 times 6 is 12, right? 12 plus 8 is 20. 20 plus 15 is 35. 35 plus 30 is 65. And here you drop the 35. That is your age. This will help you answer the questions on Erickson, right? Now, another thing that often comes up is what happens if they do actually get to a resolution? They actually go through the phase in a victorious ways, or how they should develop. You can remember this by saying how pouco full cows, which means the first H is for hope, the first W is for will, P is for purpose, C is for competency, F is for fidelity, L is for love. C of cow is for, what do you guys think? The last one here is for care. And then we have the last W, which is for wisdom. And that is point number 14. Let's move on to the next point. Okay, so topic 15, Piaget, so Peter can fly. S, sensory modem. P for pre-operation. C and the F. This is where people make mistake. The C is for concrete. The C is before F for formal. Concrete is things like conservation, reversibility. F for formal, things like science project, things like abstract, hypothesis. Topic 16, Fyodor, only awesome patriots learn the guitar. So can you guys imagine what this is about here? Well, this is a Fyodor, and the O is for the oral stage, right? The libido. The A is for the anal stage. Then we have the P for patriots. Important here, phallic. Playing with genital is normal. The L is the latency stage. Then we have the G for the genital stage, right? Adolescent years and up. Moving on to the next topic, it is the motivational therapy. As you can imagine, motivation therapy is a very high yield topic. Well, let's discuss about a few things about motivational therapy. OARS, opening the questions, affirmation, reflection, and summary. We also want to use the frame network here, or the way of thinking. It's the F is for feedback, R, responsibility, A, advice, M, menu of options, and the E is for empathetic statement. Lastly, S for self-efficacy. Plus 5 A's, we want to ask, advise, assess, assist, and arrange for care. Moving on to the trans theoretical model of change. P, com, pre, act, minutes. Pre-contemplation, contemplation, preparation, act, and maintenance stage. Topic 19, DBT, remember Marsha Linehan. It's important. Why? Because she is the creator of DBT. Only few names you need to memorize, and that's one of them, right? Marsha Linehan. And why? What is the goal of DBT, you may ask? Well, the goal of DBT is to decrease crisis, suicidal ideation. If you go back to the PDF, you have the acronym of DC steps in S so you can follow right along. Topic 20 is the humanistic. When you think of a humanistic, think of Carl Rogers. What is the principle of a humanistic Carl Rogers? Interpersonal therapy, self-actualization, and self-growth. Topic number 21. Now, here we are talking about the family therapies, and that is one of the most high yield topics. Well, let's break it down in a way that you will never forget again. Family system therapy, I want you to think of three things. Bowen is a creator, but now three things: self-differentiation, triangle, and genogram. Goal of a system family therapy is differentiation. Triangle, it's a good thing, and there is also genogram. Next therapy is the structural, right, or structure family therapy. In that, you want to have a structure like what? Like the military. That helps you remember. In doing so, you want to have boundaries. Geno, which is maps like, and reframing a different way of thinking, and do role playing. So when you hear structured family therapy, think of boundaries, Geno, and reframing and role playing. Next family therapy, it's the strategic family therapy. In here, you want straight, right? Straightforward directives, para for paradoxal, and reframing. Strategic family therapy, straightforward directives, paradoxal, and reframing is something that you always want to remember in strategic family therapy. What's the next family therapy we want to discuss? It is solution family therapy. When you hear solution, three things to remember is miracle question, exception, and scaling question. Topic number 25. This is a huge one, okay? I am going to put the acronym here for you, and you need to know Yalamo. He is the father of group therapy, right? There are a few things about Yalom that you must know. And I memorized those things that people get, why they do group therapy, by memorizing A, Hugh, Soccer. Okay, that is the acronym that I use for Yalom. So the A is for altruism, H for hope, I is imparting behavior, the second I is for imitative behavior. The third I is interpersonal learning, self-development. How about the soccer? Socialization, right? You wanted to socialize. The O is for other similar problems. In here, I'm referring to the universality, right? The C is for cohesiveness. The other C is for catharsis. E for existential factor, and R for refocusing or changing of the behavior. And there you have Yalom, topic number 25, a heel soccer. Topic 26, I want you to think of adverse child issues that happens and brings up to our adult life. And in there are several topics. They are kind of huge, like anxiety, depression, obesity, unintended pregnancy. But the one that you don't see there is schizophrenia. Okay? So take a look on our PDF and see what adverse child experience is, and make sure you know that you don't see schizophrenia. Moving on to the next topic that I would put on my dumping sheet, it is the recovery model, right? recovery model is important. Why? Because it's patient-directed. Is it linear? No, it is non-linear. And there are four things that you must know, which are the HHPC. When you hear recovery model, remember HHPC, which is health, home, purpose, and community. This will help you ace your PMHNP board certification. Last thing for our module 4 is the ACT, right? And here we are referring to a assertive community treatment. And I want you to remember this community. It will help you to remember community of doctors trying to keep the patients away from the hospital. This is it for number 4. Moving on to our module number 5. Well, there are a lot of important things, but the first thing I want you to understand, or kind of at least put on your chart, is the scope versus the standard of practice. When we hear scope, it is about the state. The state determines what you can do. The standard is set up by ANA. Now, let's discuss number 30, which is our law principle, as I like to call it. So principles in law that have affected how we practice is determined by the court. One of them is called the TERRA-SOF. So I put it here, TERRA for short, which means duty to warn, right? We discussed all about the TERRA-SOF principle in TERRA-SOF principle in our course. I'm not going in a lot of detail. The second one is habeas, which means the habeas corpus, which means unlawful detention without a due process. 32, O'Connor, which means a mentally ill patient cannot be kept involuntarily unless if he or she is a danger to self or others. The number 33 is the patient's right. What are the two patient's rights? Least restrictive environment and informed consent. Number 34, I want you to think about the Rainey versus claim, which is patient has the right to refuse treatment. Do they have right to refuse treatment if they are inpatient? Yes, they do. Okay? Right to refuse treatment. Rainey versus claim case, right? Right to refuse treatment and appeal process. Now the Roger, which is Rogers versus O'Keefe, it says the patient has the right to refuse treatment, but who can authorize? A guardian can authorize. What's next? Well, point number 36 is the Durham versus United States. In this case, it says that an individual is not criminally responsible if the unlawful act was a product of mental illness. So basically, here said German mental illness, no jail, to help you remember that. Ford, I want you to think that Ford cannot die. So Ford, this is a Wainwright. The patient must be competent to be executed, right? Killed. 38 is the Stark law, which means money under the table. You cannot accept or refer patients for money, right? Few other things I want you to put on your dump sheet, or at least consider. Number 39 is the health policy. When we refer to health policy, I want you to put a next to it FIE. You got to formulate, implement, and evaluate. Before a health policy is activated or implemented, we should first seek the barriers. Find out what are the barriers before who? the stakeholders. Does the order matter? Absolutely. Barriers before stakeholders, policy, health policy. Number 40, patient advocacy. Why? To decrease stigma. How? Through education. Number 41, just culture. What is it? No blame. Number 42, quality improvement. Okay? Why do we do quality improvement to begin with? Well, three things: improve system, decrease cost, and increase productivity. Why or how do we do this? Well, we do this by a retrospective chart review. Okay. The last topics, number 43, is reflective practice. And you do reflective practice by what? Debriefing. Guys, there are a lot of things to cover. But I want you to ensure you that these are high yield content you must know. Now, I want you to get this PDF that I'm going to send it to you. Take it, what is good for you. I put a lot of content here. Not everything you should have on your dumping sheet, right? A dumping sheet is not a book. It's a systematic of a way of you putting in the paper things that will help you conquer the PMHNP board certification. I hope you like this video. So my name is Dr. Lopez. Come study with us.